I think we are going to kick off. It's now 1 minute past 2. So I would just like to say kia ora and welcome everyone to this Fulbright New Zealand Good Work Seminar for October. We are absolutely delighted to have Fulbright New Zealand alumna Dr Stuti Misra with us today. Dr Misra is an optometrist-scientist working as a senior lecturer in the Department of Ophthalmology at the University of Auckland. Her research interests include anterior segment imaging, ocular surface diseases, and corneal innervation in systemic diseases. She is a recipient of several prestigious awards, including the Fulbright New Zealand Scholar Award and the Asia Pacific Academy of Ophthalmology Achievement Award. Dr. Misra graduated in optometry with distinction in India before relocating to New Zealand in 2005, where she completed a Master of Science in 2008, and that was in optometry, followed by a doctorate in ophthalmology in 2014, and both of those were from Auckland University. So she's going to be sharing some of her new information and research with us today. Stuti lives near the Pahudakawa coast in Auckland with her husband and her 3-year-old daughter, and she's doing an amazing job being stuck in lockdown with a toddler. So well done, Stuti, and thank you for joining us. Thanks for joining us, everyone else. And a quick reminder, if you are just joining us now, to make sure that your computer is muted throughout the discussion. Thanks.
Thank you for your introduction, Therese. Kia ora, everyone. Okay, I'll share my screen now. All right. So today I'll show you how your eyes can show strength of your soul. So before I start, I'd like to say I have no conflict of interest to disclose. I have received funding from a number of government and philanthropic organizations, including Fulbright New Zealand. So in today's talk, I'll briefly share my professional journey, and I'll share a few stories that your eyes tell about you and how important it is to have eye assessment or eye test, not just because of your eyes, but also systemic diseases and other eye conditions and other general conditions as well. So first up, about me. So as Therese said, I completed optometry degree some time ago, and that was in India, and I relocated to New Zealand in 2005, and I started my master's, and that was in retinitis pigmentosa, so that was back of the eye, and the project was funded by Retina Australia. Subsequent to that, I worked as a tutor in optometry department, now School of Optometry in University of Auckland. At that time, I was convinced by Professor Jennifer Craig to undertake a PhD in ophthalmology. So that was in, about front of the eye. So yeah, and that which I finished in 2013 and graduated in 2014. After that, I received a Fulbright Scholar Award, which enabled me to travel to America, to Johns Hopkins University, and helped me start collaboration there. And I also attended American Academy of Optometry conference that year. In 2017, I received Asia Pacific Ophthalmology Achievement Award. So that's to recognize my contribution at APAO. In 2018, towards the end of 2018, I took parental leave, which was for about a year. And I got back in second half of 2019. And as I was about to start back my research, the world changed. So we all went into lockdown, and yeah, here we are still in lockdown in Auckland for about 10 weeks. Okay, moving on. So then a few months ago, I also started to become involved with TFM and Oculus Surface Society. And I was invited to participate in ocular surface disease workshop, and I'm part of a nutrition subcommittee. So that includes experts from all over the world. So that only has 17 experts from all over the world part of this subcommittee. Okay, so over the years, over past decade, I have published in this space, in this area of relating diseases that affect your body and how changes in the eye occur at many stages, many situations prior to affecting the rest of your body. First up, diabetes is the main one that affects many parts of your body, including eyes, which I'll talk about in detail. Also, immunodeficiency virus, so that's simian in cats or monkeys, and that's or in human it is HIV. It's commonly known as. Also, Parkinson disease and chemotherapy. I'd also like to say today, just this morning, I got an email that one of the paper we did in collaboration with researchers from New Zealand, America, Qatar, United Kingdom. That study was on multiple sclerosis. So we published that. I won't be talking too much about that today. Let's moving on. So before we get started on actually the research part of it, just about the eye in general. So this was redrawn by my very talented optometry honors student, Josephine, last year. What it's showing is different layers of TFM. So you have, of course, the clear part, that's cornea. And then on top of that, you have that TFM that covers. So what we do, we image TFM as well as the cornea. Looking closely at cornea, it has different layers. So we have tools that we can actually image of the whole cornea at a cellular level in a living human cornea, so in patients. So this is a test called as Oculus keratograph. So it's essentially just taking photos and videos of your eye. What it does is it can tell a lot about your ocular surface, so the TFM. So, for example, this one is about tear meniscus height. So what it's saying, it's telling us how much tears sit on your eye, on the lower lid. So that it actually can measure that. And also this one is tear breakup time. So how it's essentially like a staring contest, how long you can keep your eyes open. So this one tells us the dry spots that you can see or the first time they appear when you're keeping your eyes open. We also do a look at meibomian gland. So like I showed you just moments ago, that the top layer of TFM, so that's the lipids, that's the oil. So that oil is essentially secreted by these glands. So we can image them using infrared techniques. And this is, we lose these glands in many diseases that I'll talk about today. This one also measures redness. So we also clinically say, okay, there is redness is condition, but this tool allows us to image and keep a record of redness. So it gives you a number. So when patient comes in later on, you can actually tell whether there's an improvement or not. Thermography, or this one measures your temperature profile of the eye. So these days now, everywhere you go, your temperature is taken for various reasons, not necessarily the eye. But this is, and of course at airports now, that's become, I think over the past decade, it's become really common everywhere, essentially. So in terms of eyes, what it does is, we can create a temperature profile. So it doesn't mean that just by temperature you can tell whether you have dryness or anything wrong with your eyes. So what we want to measure is something called as temperature variation factor. So in the clear part, so the edge of cornea, that and till the center of cornea, The difference of temperature between those 2 points is temperature variation factor. So as you can see in this graph, so it's higher and it's cooler in the center. And in dry eye, this factor increases. We have some other interesting tools that we employ. So this is called tear osmolarity test. So essentially just testing salt content in your tears, and that determines if there is any inflammation in your eye or dry eye. So you collect tears just on the edge. So it's ticklish. It's not necessarily, it's not invasive, but you can just very tiny amount of tears. This one literally sucks out, and then we dock it into the system, and it spits out a reading. And so this tool called non-contact corneal anesthesiometer is quite a mouthful. What it essentially is, it's a corneal sensitivity test. So how much you can feel in your eye. So we know there are the corneal nerves, or in the clear parts, it's really hard because you can touch your skin, but you really can't touch your eye like that. So that's a test we use to determine that sensitivity. And this particular one was developed by our collaborator, Dr. Simon Dean, who is Watson Counties, and he is full-time ophthalmologist, but we call his part-time engineer as well. So what this one is doing, it shoots air in your eye, and then patients just says whether they feel it or not. So some of you might have had a similar test where an air puff measures your eye pressure. This is feels kind of similar, but it is measuring a different thing essentially. So this one is measuring your corneal nerve function, so to speak. We've also started to use this technique called as flush technique. So this was pioneered by our collaborator in University of New South Wales, Dr. Associate Professor Maria Marculi. So what we do is we put saline in the eye, and in a few seconds we collect using a tube. And those tears are then frozen in -80. And afterwards we process them in the lab and test for different markers. And for what markers? So to test inflammation, so that and also neuropeptides. So we know in diabetes there are changes reported in tears as well. So this one is our quite an important tool, and specifically for me, I employ this technique called in vivo confocal microscopy of cornea. So this visualizes the corneal, each of the corneal layer at a cellular level. So we can actually see the cells, each cells in all the layers. And it scans. So this one is meibomian glands. So remember, I showed you flipping the lids, so you can see those individual cells too, and as well as the corneal layers. And it's actually really quick. So what it's doing is it scans, as I said, so I showed you the cross section, but this one is going from anterior to posterior, so from front to back. And what we're looking at here is these are the cells here in epithelium, and these lines, this is actually extremely important for our work. So that's the corneal nerves in subbasal plexus, what we call it. And these are deeper layers of cornea, and that's endothelium. So each of this image is about 400 by 400 microns. So essentially it's about 0.4 millimeters in size. So it's extremely tiny. So how it is relevant to systemic diseases? Well, eye is related to the rest of the body. And in terms of cranial nerves, are considered a part of peripheral nervous system, of course, except the second nerve. And repeated examination is not possible, especially in terms of assessing peripheral neuropathy. So changes in feet, you cannot do, for example, skin bunch biopsy at the same site multiple times to see whether there is any changes in neuropathy or not. So So traditionally, how diabetic peripheral neuropathy, it is extremely common, and it's assessed with history taking, just asking a lot of questions to patients, clinically examining them, doing biophysiometry. So what is biophysiometry? I'll tell you more about that. So essentially this one, so how I explained about that eye sensitivity test or corneal sensitivity test, this is feet sensitivity test. And that only takes a few minutes as well. And then is nerve conduction test studies. So this is also that's done by specifically by neurologists. That's not performed by us. But there is limited sensitivity for early detection in all of these techniques. So there are several limitations for assessment, not just for diabetic peripheral neuropathy, but neuropathy that is caused by several diseases. So we need a test that is early detects and which is fast and it is non-invasive, which means that does not hurt at all or not painful, which is objective and also reliable. So we employ a number of tools. So I mentioned a few already. So that was for Oculus surface. And for most of our projects, our research projects, we do a few different tests. So of course, vision, corneal sensitivity, confocal, and also duration of blood tests and BMI are quite important, and especially when I talk about diabetes and bariatric surgery, that's of course that's quite an important outcome measure as well. We ask for neuropathy questionnaire, so that's to understand about symptoms of neuropathy if there is any, and neurological exams. So that's conducted by doctors within our team, and also some of them are done by our specialists. So I was mentioning about nerve conduction tests. So this is what it looks like. So these are tests of the speed of conduction of impulses through a nerve. So it's literally, it's an electric pulse. It's that, and it's passed through and it's noted, and it is objective, but it is very expensive and it is performed by a neurologist. This one is biophysiometry, so that feed sensitivity measurement. This does not hurt and is very quick as well. In terms of nerves measurement, what outcome measure, what we are looking at? We're looking at nerve density on corneal nerve fiber length. So this is done in a semi-automated way. We're using different software which are readily available. For example, Image, NeuronJ plugin, and there are some other software that can be utilized too. However, we have been working on another software, automated software, in collaboration with Dr. Oakley and Professor Minkowski in America. And that work essentially started during my Fulbright visit. So this method employs deep learning and artificial intelligence, so to speak, to measure and do these measurements and by just blink of an eye. So we have published that, and there is a lot of work going on in this space to ensure clinicians can use these on a regular basis. What other things we are looking at is this MONTAGE. So again, those nerves I was telling you about. So this, so we do prepare a map. So as I said, this is 400. Each of this image is about 400 by 400 microns, or 0.4 millimeters. So under our cornea, horizontally, it's about 12 millimeter plus minus or so. To map a larger region, you need to, of course, scan a larger region, and then it is like a jigsaw puzzle, essentially. We put this together, and what we notice this is it's forming a nice anastomosing network and forming a vortex inferior centrally. So, and we did see that there are no changes between the eye, which we found was extremely interesting. But why is that important? So this is a normal cornea, but what happens in diabetes? So as you can see, these two are of diabetic cornea. So you can see there are significant gaps here. So there is reduced nerve density here. And what's happening in this one? So these both are type 1 diabetes patients, but you can also see some cells here. So this one I'll talk more in detail. So this patient has been a contact lens wearer for an extended period of time. So before I go or talk about more about those cells, let's look at the results. Some of the results from my doctoral study. So this is a busy slide, so I don't want to overwhelm you with all this data. So this, but I'll just break it down for you. So this one we are looking at, this column is on controls, so no diabetes or no other disease. And column on the left, that is on patients with diabetes. So as if we look closer in this, so there is, so what is this mild, moderate, severe? So this is neuropathy. So the worse the neuropathy, the lower the corneal nerve density. So that has been, that's been recorded in the literature as well. So we can say that this is an objective biomarker for diabetic neuropathy, which is a more reliable and objective marker than history taking or doing feed sensitivity test, and definitely less expensive than nerve conduction test, and much less invasive than skin bench biopsies. Another interesting thing that should point out is this measurement of microalbuminuria, so which is checking nephropathy, your kidney function. And we can see in many of these, your kidney function, it's generally considered as a predecessor. So these changes in your kidney occur at a much early stage, but we have shown that the changes actually are occurring and in the eye much prior to development of any nephropathy, neuropathy, or even retinopathy. So retinopathy is in the back of the eye. So changes in the front of the eye are affecting. So this is the one showing my PhD studies. You can see it's almost 50% changes in numbers in terms of corneal nerves. Now let's look at the Langerhans cells. So the cells that I showed you in those tiny maps of patients with diabetes. So these cells are antigen-presented dendritic cells in the top layer of the cornea. So that the corneal layers I showed you cross-section is in the front, just in subbasal nerve, so just underneath the epithelium. And they normally found in peripheral, so it's at the edges of cornea. So that's at the junction of the clear and the white part. And they activate T cells when there is corneal immune response. And in pathological states or in disease, they move towards the central cornea. And these cells, you can see that when you scan. And they're specifically present in keratoconjunctivitis sicca. It's quite a mouthful again. This is nothing but severe form of dry eye disease. So with diseases that have this involvement, the severe form of dry eye, potentially there is a role for monitoring systemic diseases there. So in which diseases? So Sjogren's disease. So Sjogren's disease is a chronic disorder that affects exocrine glands. Essentially, you get dry mouth, dry eye, and we have noticed that there is increased those Langerhans cells, so those dendritic cells that I showed you, and decreased meibomian glands. Again, those flipping of the lids that I showed you earlier, those change as well. Rheumatoid arthritis, you know what is rheumatoid arthritis, and that is a disorder affecting the joints, and we do notice severe form of dry eyes and also increase in those dendritic cells. Systemic lupus, so that affects multiple organs again, and that causes severe form of dry eyes again, and we have noticed there is a significant increase in those dendritic cells. Ankylosing spondylitis, that's again, normally you would have seen these patients, they tend to have a crouch at some stage in their life. And that's often associated with uveitis, so that is internal eye infection. And again, in these patients as well, there is severe form of dry eyes, and that correlates with serum inflammatory markers. So what is serum? That means in your blood. Okay, so like your ESR, so that's erythrocyte sedimentation rate. So that's again, or CRP, that's C protein, C activate protein. You see the changes you can see in the blood, but you can also see in the eye as well, at much earlier stage. So to looking at relevance to systemic diseases, so in terms of corneal nerves, there is, you can note peripheral neuropathy in the eye of various etiologies, not just diabetes. And I'll talk about more of these peripheral neuropathy in different diseases momentarily. How this can be a potential biomarker for diagnosis. Not just that, but for diagnosis at an early stage, and also monitor this as it progresses through the course of the disease. In terms of Langerhans cell density in several systemic inflammatory conditions, you do notice that especially that cause that severe form of dry eye. And as I mentioned, it does correlate very well with results in your blood test inflammation markers that we see in the blood. And potentially it can also be used as a monitoring tool. So coming back to those diseases that cause peripheral neuropathy. Parkinson's disease, of course, we know it has major impact on one's body. And of course, peripheral neuropathy as well. And we do get to see a number of ophthalmic findings. So that means that there are a lot of changes happening in back of the eye. So with retinal fiber thinning, so specifically in the color vision changes, color vision defects. Also, we also get signs and symptoms of dry eye. So our aim was to see whether whether Parkinson's disease has any association with the corneal nerve microstructure and establish a relationship between them with the severity of Parkinson's disease. So as you can see in this one, this is a representative image. So on the left, you have patient with Parkinson's, and on the right, healthy, age-matched, healthy control. And you can easily see without doing any analysis, there is significant reduction there. For those who like to see things in graphs, so you can easily see in this box on this plot, the patients that have Parkinson's are much lower. So just so you know, less is bad. So like if you have reduced number of corneal nerves, that's leading to corneal neuropathy too. And in age-matched control, because we always talk about people of similar ages in any research as well, and that's almost double. When we look at relationship between ASR, so what is ASR? ASR is Addenbrook's cognitive examination revised. So that is an indicator of presence of dementia. When we correlate that with these corneal nerve, there is an association, you can see a trend, which is statistically significant and showing a moderate correlation as well. And if you want to read more about that, you can, paper is available online. I'll talk about weight loss surgery or bariatric surgery and diabetes. So this is an exciting project that we started a few years ago, funded by HRC and New Zealand study of diabetes. That was, so what happens with weight loss surgery over the past few years, we have seen an increasing number of surgeries happening, and it is an effective option for morbid obesity. And we know that it causes diabetes reversal, What we didn't know whether it's leading to any reversal in eye changes, because we know there are changes happening due to diabetes in the eye. So our aim was to assess patients with diabetes who undergo the surgery. So we assess them before periodic surgery, before weight loss surgery, and after at different time points for the course of a year. To whether specifically to see whether there is any regression, there is any reduction, or there is any progression, or whether it's stabilized in relation to peripheral neuropathy. So in the next few slides, in the next 2 or 3 slides, I'll talk about the results. So this is unpublished data. So and I've only presented it at the NZSSD conference in Wellington in May this year. It's not out in the public domain yet. So I'm very excited to share this data with you today. So what we saw, as expected, BMI or body mass index that reduces. So this is in weeks. So that's 0 is before surgery, 12 weeks after surgery, 26 and 52 weeks, that is a year. There is a sharp decline in BMI after 12 weeks, 3 months, as expected, and that's stabilized. That's continued over the course of a year. HbA1c, so that is glycated hemoglobin, that we know that is a measure for diabetes, and that's reduced as well, and that also stabilized after 3 months through until 1 year. And then if we look at corneal nerves, what's happened here that was excited us a lot. So then the first 3 months, there is an increase. So remember, lower the nerve density was the corneal neuropathy. So that improved within the first 3 months. But after that, it sort of stabilized. So most of the improvement that's happening after the surgery is in the first 3 months, and stayed that way for a year. And in corneal sensitivity test, which is the complicated name, NCCF, and so that's so in terms of numbers, higher the corneal sensitivity threshold is, worse it is. So if for improvement, it has to reduce. So that means when the threshold reduces, your sensitivity improves. So then you're reducing in numbers, and again, it is stabilizing throughout the course of 1 year. When we correlated that with peripheral neuropathy, it showed significant correlation, association as well with density and peripheral neuropathy, which we found was very exciting. Moving on from there, chemotherapy. So chemotherapy causes significant toxicity, and that's about 80% of patients. And this causes peripheral neuropathy as well in a number of patients. There have been several case series, recent case reports, and few papers, studies as well on ophthalmic findings. So we know that there could be visual field defects, or patches of vision could be lost for temporarily at least. Again, color vision defect or optic neuropathy, which is swelling in the back of the eye. We also see signs and symptoms of dry eyes. So our aim was to assess peripheral neuropathy in those undergoing oxaliplatin-based chemotherapy. These patients had colorectal cancer, and specifically wanted to determine association with ocular changes at different stages of treatment. So this was one of the most challenging study that I've done over my career. So colorectal cancer, it is a life-changing diagnosis. It can be life-changing event for all the patients, most if not all. So most of them agreed, were very helpful, and decided to participate in the study, who we approached. But afterwards, it became quite difficult as chemotherapy progressed. So we did have a lot of patients recalibrating their life and reprioritizing their life, and we couldn't continue assessment on those patients, and a few of them did pass away as well. Just to give you an idea, so this one on the left, so that's no control participants, and this one is, again, there is a patient who has had a cycle of oxaliplatin-based chemotherapy. So I'm not going to share the results, which is that's in the preparation for publication at the moment. So, but I can say this is one of the most surprising results. Was surprising. We did not expect that at all. I'd also like to talk about immunodeficiency virus project. So that was the one that started during my Fulbright trip to America. And so as you can see, these nerves, they are actually not that different in humans. And when you look at macaques and different types of macaques or different types of monkeys. That was in that these are in normal, as normal one, as in without any disease. With in acute semin deficiency, or SIV as we call it, that changes as well. So we have published that. We've had a few publications on the topic, and a few are in preparation. And there are a number of studies happening in human immunodeficiency virus, or HIV as well, where we see peripheral neuropathy, although the treatment is good in that, but there has been reports that does affect eyes as well at an early stage. So finally, I'd like to say most of these tests, they can be used not just for early diagnosis or assessment, but for screening purposes on a regular basis to keep a tab on not just eye diseases, but diseases in the rest of your body as well. In terms of, there are multiple clinical applications, as well as, so it can be used in the clinical setting as well as for research purposes. So for research purposes, if there are any studies on novel treatment modalities to assess those, these tools can be used to keep an eye on changes in peripheral neuropathy as well. So today I shared with you my professional journey and what stories your eyes can tell about you. And how important, how crucial it is to have eye assessments, not just because for your eyes, but for the rest of your body as well. Of course, I'd like to acknowledge my mentors, my colleagues, my collaborators, students, and importantly, participants and patients. Thank you.
Thank you so much, Dr. Misra. That was really, really interesting. And I'm really grateful that you did use a lot of sort of layperson's language there, because even though it was quite sort of in-depth and there were a lot of really interesting charts and things, but even though you were using that sort of language, I was still a bit lost at times. So but yeah, that's just me. But no, I really appreciate you sharing all of that information and really fascinating research with us. Thank you. And if anyone has any questions, do please feel free to is that okay with you, Stuti, if anyone wants to ask a question now? Okay, so if anyone has a question that they'd like to ask, you can either unmute your computer and just ask, or you can pop your question in the chat box, whatever suits. If you don't want to ask a question right now on this recorded YouTube seminar, that's absolutely fine. You can always email Stuti afterwards with your question. I'm sure that would be okay.
Yeah.
Well, it looks like we have, is there a question from someone? No?
I have a question.
Sure.
Is it, and I've written it down in the chat box, so forgive me, I'm going to read it. Is it possible to extrapolate the relationships between what I call submicroscopic indicators in certain diseases to a macroscopic level?
Mm-hmm.
In other words, you know, all the data you're collecting is submicroscopic. Those are my lay terms, but you're showing relationships to diseases. can you then extrapolate that to if I'm looking you in the eye at a macroscopic level and reading your eyes, if you're familiar with that sort of homeopathic type approach?
So you can, it's because eye is such a small structure. So looking at on a macroscopic level, it is quite hard. So just looking at just like that, like naked eye, as we call it, it's extremely difficult. So yes, we are looking at microscopic at the cellular level, but the changes you do see in general as well in terms of symptoms. So that's why symptoms play a role. So there is an association of a lot of these changes that are happening at a microscopic level. That do translate at times in terms of symptoms. But looking at in the eye, just that becomes extremely hard. If you don't have those tools, I'm afraid it's hard to tell, be very objective, but signs and symptoms, they do correlate.
Yeah, and hopefully you can appreciate where I'm coming from.
I understand. Mm-hmm.
There are different cultures around the world where humans look into other humans' eyes and they ascertain, they allege that they can ascertain various underlying diseases through that type of approach.
Yes, I can tell it's definitely not possible but just by looking. What you can tell, however, at times, certain things, for example, like how I talked about those glands that are in the lid margin. You can see those changes by flipping the lids, but not at the cellular level, but you can appreciate there is something going on there. Maybe not what is going on exactly at the cellular level, but you can just at least say that this is not normal, right? So that's that may or may not correlate with the systemic diseases. But what you can tell clinically, what I can tell if I'm looking, if you go to your optometrist or your ophthalmologist, you can just looking at those, that's microscopic level as well. And we do seldom use just a torchlight as well, which you can just tell whether there's something right or wrong. But again, it's hard to pin down at exactly what is wrong with just looking at a person like that. So scientifically speaking, I would say no. But yeah, that's the jury is still out, I suppose.
Thank you. Excellent presentation.
Thank you.
Thank you. Okay, if there's no other questions,
I have a question.
Sorry,
if I can. Paul Hewitt here from Hamilton. I was just very fascinating about being able to pick up health issues. I was wondering, conversely to that, are you able to identify perhaps traits which might be extremely useful for other activities, i.e. if you can tell somebody has heightened O2 uptake, so therefore they may be a good long distance runner, or somebody may be better suited for other activities. Is that something which has been investigated, or is that something that you notice at all in the studies?
That's a very interesting point. Yeah, thanks for that. We haven't flipped that around. So you're saying if you have really high sensitivity of your cornea, is whether you can do certain things. No, we haven't studied that yet, but that's an extremely interesting point. Perhaps if you have excellent, like if you're doing in a staring contest, if you can keep your eyes open for an extended period of time without causing dry eye, perhaps. We haven't done any research on that. It's a very interesting thought.
Okay. Yeah, because I mean, I noticed like with the sports science and that, I mean, you can identify somebody who have a propensity to be a better cyclist, or somebody might be a better swimmer through, muscular skeletal actions. So, yeah, so just interesting.
Perhaps that could be a study. I'm just thinking on the go here pretty much of the fly that if there is a high reaction time, there is quicker reaction time. So perhaps that could be interesting, because I know there is some research, not exactly in the space of corneal nerves, but I know there's some research going on that's sponsored by Cricket Australia that's looking at how quickly you can see the pink ball, for example, if you're familiar with cricket. But not necessarily using these tools that I'm using, but that does happen. The research is not so much in New Zealand, as far as I'm aware, in that space. But I think there is definitely potential to think about that. Yeah.
Okay. Well, thank you very much. Enjoyed your talk.
Thank you.
All right. Thanks for the question, Paul. It sounds like you've potentially opened up a whole new line of research for Stuti. Okay, thank you so much, everyone, for joining us. And thank you again, Stuti. That was a really, really interesting talk. And I really appreciate you sharing your knowledge and your expertise with us. So thank you. And just to everyone else who's online, we will be having our next Good Work seminar is in November. The date hasn't been set yet, but I will let everyone know. And our presenter will be Manulani Maya, who is coming in from the University of Hawaii. So thank you, everyone, and thank you again, Stuti. We'll see you all again next month. Okay, bye.
Thank you.